Hi guys, next up is immunoglobulin G4 related disease, and to make you understand what this disease is all about, I would like you to focus first on this X-ray. Even a non-medico is gonna be scared on looking this X-ray because you can see a well circumscribed mass in the right upper zone of this patient. And when you tell the family member or the case per se that I'm suspecting a lung tumor, you can imagine the amount of fear and the fright and the disappointment written right on the face of a patient, because tumor itself is a huge big word or emotional trauma to anybody. Now, when bronchoscopy will be done, subsequently, when the biopsy will be done, and when the biopsy report will come, you can imagine the joy on the face of a patient when you tell him that this was a false alarm. What I mean by a false alarm is that this particular condition that we're discussing is actually a inflammatory, or it presents as inflammatory pseudotumors. Inflammatory because there is a lymphoplasmacytic infiltration of the lung tissue, and the plasma cells here can be demonstrated by flow cytometry, that would be CD138 positivity, and we have immunostains available by which we can demonstrate the presentation of immunoglobulin G4. So this condition is an inflammatory pseudotumor. You can imagine the amount of relief on the face of a patient from the depths of extreme depression where, oh, I'm going to die of a lung cancer, to a condition where you're going to tell that this is a pseudotumor, and more importantly per se, this condition responds to steroids. So we'll talk about the treatment part later, but I would like to remind you that when you read about this topic in pathology, then immunoglobulin G4 related disorder is usually described as having a presentation as tumefactive lesions. What you mean by tumefactive is they look like a tumor, but actually when you do a workup, it is a lymphoplasmacytic infiltration of the tissues, and it is amenable to steroids, or it responds to steroids. In fact, the second image that you're seeing on the slide at the moment is a CT abdomen, and you can look at the abnormal morphology of the pancreas where the red arrows are. The description for the pancreas of this condition, or the pancreatic involvement of this condition, is itself a condition, or rather a MCQ, that is referred as sausage pancreas. Or instead of sausage pancreas, we might be using the conventional term type 1 autoimmune pancreatitis. But the main message is that when you look at this bulky pancreas, the thought process of yours as a doctor might be that this could be a pancreatic adenocarcinoma. You're aware the founder of Apple company, Steve Jobs, he had a pancreatic cancer. He died because of a pancreatic adenocarcinoma. So it's a very aggressive tumor. But then when we are going to work this patient up, it's going to be shown that this guy is not having a pancreatic adenocarcinoma, but rather a condition that we're discussing at the moment where it's a lymphoplasmacytic infiltration into the pancreas. IgG4 deposits are present here, which can be demonstrated by immunostain, and this condition can again respond to steroids, though due to the bulky growth present here, there can be a presentation of obstructive jaundice as well. Therefore, let's make a list of what are the common organs which are involved in this condition. And most of the time, either it is the pancreas, and in case pancreas is involved, both the exocrine and the endocrine involvement will occur. The exocrine involvement would imply that the production of amylase and lipase from the pancreas is hampered, and therefore diarrhea would be a presentation, weight loss will occur. But later on the same patient, the endocrine component is also hampered, which results in diabetes mellitus as well. So during the clinical part, I'll be describing that diabetes mellitus component of the disease as well, but I've given you a heads up. Then even the biliary tree can be involved in this condition, and this can look like primary sclerosing cholangitis, or it can look like cholangiocarcinoma. But again, then both primary sclerosing cholangitis and cholangiocarcinoma tend to have a bad prognosis, but this condition will subsequently respond to steroids, and involvement of the biliary tree would again cause a development of obstructive jaundice. Then another important area that can be involved is the major salivary glands like parotid or the submandibular. Now, traditionally, you are aware that in parotid gland, we can be having a benign tumor by the name of pleomorphic adenoma, malignant tumor by the name of mucoepidermoid carcinoma, but the biopsy in this case will reveal there's no mucoepidermoid carcinoma, but rather a lymphoplasmacytic infiltration. Apart from this, even the periorbital tissues can be involved, or even the lacrimal tissues can be involved. So because of the periorbital involvement, I can say, or the lacrimal gland involvement as well, you might be thinking that you're dealing with a lacrimal gland tumor per se, which again tends to have a bad prognosis, but ultimately response to steroids would be seen. Then apart from this, lungs can be involved due to the involvement of the lung. If it's a central lung mass, which looks like the impression that you're seeing on chest x-rays, that this is a central lung mass, then it can also cause local pressure. It can local pressure on the airways, and if in case this turns out to be peripheral, then no big deal, even pleural effusion can be developing in these patients, and a couple of these patients can have inflammatory manifestations also. Asthma can be there, and eosinophilia can also be present. So a very peculiar disease that we're discussing at the moment, which looks like tumors and can cause even manifestations of pleural effusion subsequently. Then apart from lungs, kidneys can be involved. The involvement of kidneys can be explained by the fact that ureteric fibrosis can be present, and this ureteric fibrosis can result in hydronephrosis in the kidneys. Then thyroid involvement would be in the form of Riedl's thyroiditis. That's again, when you read the thyroiditis topic, we read about D. quervain's thyroiditis, but in the end you always read the word Riedl's thyroiditis, which could be a presentation in this disease as well. And because Riedl's thyroiditis will cause a stony hard consistency or a very hard consistency of the thyroid gland, you again would be thinking, because when you feeling the thyroid gland on examination, the stony hard consistency always makes you think in terms of a cancer, but it will turn out to be steroid responsive lymphoplasmacytic infiltration per se. Then retroperitoneal tissues are involved. The retroperitoneal tissue that's usually involved in this condition is ureter. Therefore, ureteric fibrosis is the manifestation, and then ureteric fibrosis results in a kidney involvement. Over and above this, rare involvements can be of the brain. So I'll be describing even terms like diabetes insipidus in this condition. That's the central variety of diabetes insipidus. Growth hormone deficiency, meningeal involvements can be occurring. Even joints can be involved, bone marrow can be involved, and even the mucosa of the gut can be involved. So this disease per se can have a myriad manifestations, and lots of time we might be initially doing a whole body PET scan in these patients as well, because if you are having multiple involvements of multiple areas of the body getting involved, and there growth present there, you will think that there could be a tumor originating in one of the tissues, and that has spread to other tissues, and that is why I said a whole body PET scan would be also done in these cases. The histopathological findings will also be given in the exam and will be a main determinant for answer in the MCQ, because one, there would be immunoglobulin G4 plasma cell infiltrate. I said for immunoglobulin G4 we have immunostaining available. For plasma cell demonstration we would be having CD flow cytometry markers available. And then you can see this crisscross, I would say the crisscross infiltration of tissues that is happening. So this crisscross appearance is given a very peculiar name, and that's one of the good pickup points in the MCQs that you need to remember. That is storiform fibrosis, and the storiform basically means a interwoven appearance, like a garment would be having interwoven, or a mat would be having interwoven appearance. Similarly, a interwoven appearance here is referred to as storiform fibrosis. This disease can involve the blood vessels also. So from the pathology perspective, remember veins involvement can occur, even arteries can be involved, but the venous involvement is one of the characteristic ones that is seen, that is obliterated phlebitis, though it's not present in this slide. In this slide, what has been shown is mainly this crisscross appearance that you can see. In fact, I can say this looks like a rosette, but is not a true rosette again, and therefore the term that's used here is not a rosette, but rather storiform fibrosis. Coming to the clinical features of the disease, usually it is the pancreas that is involved, and initially it is going to be the exocrine component of the pancreas getting hampered. Because of this, the production of amylase and lipase will be hampered. Because of this, I will think initially that I'm dealing with a case of malabsorption syndrome, because there would be osmotic diarrhea, because sugar is not getting absorbed due to deficiency of pancreatic amylase. There can be steatorrhea as well, because pancreatic lipase is not there, and there would be concomitant weight loss occurring in this patient. Subsequently, even the endocrine component of the pancreas will get involved. For this endocrine involvement, because there would be damage to the beta cells, as a result of which the person will end up with manifestations of diabetes mellitus as well. So on the workup of this patient of malabsorption syndrome, I'm finding that there is gonna be presence of elevated blood sugar, fasting more than 126, 2R values more than 200. The cutoffs for diabetes or impaired fasting glucose or impaired glucose tolerance can be present in these patients. The reason why this is happening is, however, the lymphoplasmacytic infiltration into the pancreas, which is described as type 1 autoimmune, not type 1 diabetes. I'm writing type 1 autoimmune pancreatitis, and the damage to the pancreas will explain the subsequent damage to beta cells, and therefore, or the pancreatic mass is basically reduced, and it's replaced by the fibro-inflammatory infiltrate that is present. That's gonna be mainly the plasma cells along with immunoglobulin G4 deposits in the tissues of the pancreas. In fact, this growth that is occurring in the pancreas can even press on the biliary pathway. In fact, if the lesion or if this tumor, pseudo tumor, is present in the head of the pancreas, that is when it can contribute to development of obstructive jaundice. It can be causing development of abdominal pain. So features that could be mimicking even features of pancreatic adenocarcinoma can be, because weight loss is anyway there. The reason for that weight loss is obviously the diarrhea component, the osmot, because nutrients are not getting absorbed. But because there is a weight loss, because there is obstructive jaundice, since the growth might be occurring in the head of pancreas and abdominal pain, we might be thinking that person is having pancreatic adenocarcinoma, though later it turned out it was immunoglobulin G4 deposits. Then, as I explained earlier, even biliary tract can be involved. The involvement of the biliary tract can again result in obstructive jaundice and abdominal pain, and therefore I can say that the biliary tract involvement in this condition will usually mimic the manifestations of either cholangiocarcinoma, or it will be mimicking manifestations of primary sclerosing cholangitis, that is PSC, though PSC is caused by P. ANCA and can be an extra-intestinal manifestation of inflammatory bowel disease as well. Then another very peculiar manifestation which is worth remembering is that those salivary glands are involved, periorbital tissues are involved in these patients, but in some of these patients you could be having even ENT involvement. That ENT involvement could be in the form of presence of nasal polyps, and then along with this an allergic manifestation, which when I was describing the lung profile, I had said asthma could be a presentation along with eosinophilia, and allergic rhinitis can also be present. So per se, ENT involvement of the disease is in the form of what I've described for point number 3 before you. And then as I've explained that there could be orbital pseudotumor, and because there are so many manifestations which are coming up, I mean, there would be a pseudotumor presentation of all tissues in the body. So what I'm going to do subsequently is, once I've described this, I'll show it on a diagram on like this, where I'll talk about the common manifestations that you have to remember from the exam perspective, because there's a big table in Harrison. We need to filter out, we can say we can filter out the noise and focus on the core issues. The ENT involvement, as I mentioned, could be in the form of allergic rhinitis in these patients. It could be in the form of even nasal polyps, as I explained. It could be associated with eosinophilia. But over and above this, even the pituitary can be involved. The lesions in the pituitary can be damaging the posterior pituitary, so they can be central diabetes insipidus. If the anterior pituitary will get involved, then the production of 6 hormones from the anterior pituitary can be hampered as well. So even endocrine manifestations could be occurring in these patients. The arrows at the eyes, so I've already explained that there could be a lacrimal or a orbital pseudotumor. You might think that this person is having a lacrimal gland tumor, turned out to be a steroid responsive immunoglobulin G4 related disease on a biopsy. Similarly, parotid enlargement can be seen, submandibular enlargement can be seen. So major salivary glands can be involved in these patients as well. Then if you go down into the thyroid, it could cause a presentation of Riedl's thyroiditis, which will be a stony hard Riedl's thyroiditis is always stony hard consistency. It mimics anaplastic cancer per se, but turned out again immunoglobulin G4 deposits. Apart from Riedl's thyroiditis, we also have a fibrotic variant of Hashimoto's thyroiditis. Hashimoto's is that autoimmune thyroiditis that we read, where we read about anti-TPO antibody, that is thyroid peroxidase antibody. So the fibrotic variant of Hashimoto's thyroiditis can also be kept as one of the presentations of the disease. Then comes the lung involvement. From the lung involvement, one I've tried to symbolically show that they can be pleural effusion. If in this case the inflammatory lung pseudotumor is towards the periphery, it will cause pleural reaction and therefore pleural effusion will occur, or it could result in an inflammatory, as I've explained, it could be causing a lung pseudotumor. This lung pseudotumor can cause local bronchial compression. That local bronchial compression can cause breathing issues as well. Then from the cardiac perspective, I can say that the blood vessel that is originating from the heart, the main blood vessel originating from the heart can be involved. So they can be aortitis. Then pancreas can be involved, that I've already explained. The description from the radiological perspective is called as sausage pancreas and can mimic a pancreatic adenocarcinoma. The kidney I've shown symbolically increased in size. Why? Because they could be hydronephrosis, it could be unilateral, it could be bilateral. And the reason for this is the retroperitoneal growth of this pseudotumor. Because of the retroperitoneal growth of this pseudo tumor. Therefore, they can be a ureteric fibrosis. Ureters are retroperitoneal. Traditionally, we read about retroperitoneal sarcoma, but here I'm teaching you, see, ureteric fibrosis, it could be unilateral, it could be bilateral, and as a result of it, it can result in development of hydronephrosis as well. And then the hepatobiliary manifestation, the green is the representation for the gallbladder and the biliary tree. So I can, as I explained earlier, manifestations identical to that of what we encounter in cholangiocarcinoma, that could be in the form of obstructive jaundice, where mustard yellow discoloration of the urine can be seen, could be presentation of this disease. So this table basically helps us give us an idea with respect to the myriad manifestations of the disease. A single patient can be having all of these, or different patients, like one person could be having only a orbital tumor, another person could be having, let me say, salivary gland tumor, and when the biopsy was done, the diagnosis was made, then remaining manifestations will not occur. I explain that again. I'm not saying that a single patient will be having all of this. Suppose somebody is having a parotid mass, it will grow fast. So as a result of it, he will come to medical attention, and you will be able to, work it out that this is not a pancreatic tumor. This is not a parotid tumor in a sense. It's not a pleomorphic adenoma or a mucoepidermoid carcinoma, but is rather a steroid responsive condition. So per se, most of the time, it may not be all of them, but only few manifestations that are present, and biopsy will invariably be done in these patients, primarily because we are suspecting a tumor. In fact, we might even be doing a whole body PET scan in these patients to check out whether could be a malignancy that is disseminated. And as I've explained earlier in this short topic, that the main treatment for this condition would be steroids. And in case steroids are not working in some of these patients, there might be even a requirement of rituximab. Yes, the same anti-CD20 molecule that we read about non-Hodgkin's lymphoma as well, a couple of other hematological conditions, is being discussed once again. So the mainstay of treatment is steroids and rituximab. And the key word in the question that would help you crack that, okay, I'm dealing with immunoglobulin G4 related disease, would be the histopathological aspect, where the word storiform fibrosis will usually be given. In fact, two topics where I can say that histopathology in your exam will play an important role. One would be storiform fibrosis for immunoglobulin G4 related disease, and second would be a term that I've said in hepatology, interface hepatitis. That interface hepatitis is a feature that's encountered with autoimmune hepatitis. So do read about autoimmune hepatitis as well. That's discussed in the liver section, but there that histopathological term interface hepatitis would play an important role with respect to the final interpretations of MCQ in the exam. So these are the details for this relatively a short topic. Keep the pressure on, keep hammering, keep on learning new topics every day, and you would be able to be successful and break on to the other side.